Good morning, everyone. Welcome to this workshop, the workshop number 5 du Réseau Québécois COVID-Pandémie. This morning, we'll be talking about, I think, a topic that is on everybody's mind: what next after the vaccine? Now, my name is Michel Rochon. I'll be your moderator this morning. I'm a health and science journalist who has covered for more than 30 years the field. I've done many epidemics, and I've covered many topics concerning what we'll be talking about this morning, vaccines. I'm author of 2 books on the brain. I'm a lecturer in journalism, and I'm a moderator. That's what I've been doing for about 15 years. So this workshop is 1 hour and 30 minutes. It's quite short, so I'll be the guardian of time for you people. I'm going to start by presenting the 3 distinguished guests that we have this morning. And then I'm going to start with the first topic. Now, this is for you to ask questions. This is a Q&A workshop. So please use what's at the bottom of the Zoom Q&R and ask questions. I will read them as we go along, and I will be conveying your questions to the distinguished guests that we have this morning. So this is recorded, so please become aware of that, let's start. So talking about vaccines in this pandemic was quite a feat, both on the research aspect of it and on the public opinion aspect of it. So this morning we'll focus basically on the research. I will present the 3 distinguished guests, and then I will give them 5 minutes to give us an overview of their work, and also to focus on what we're going to be talking today. So we have our first guest, Jason Kindrachak. Jason, welcome. This is our distinguished guest from Manitoba. He is assistant professor at the Max Rady College of Medicine, in charge of medical microbiology and infectious disease at the University of Manitoba. And we have the Dr. Marie-Josée Hébert, which is Vice Rector of Research, Infection, Immunity, and Inflammation, full professor at the Faculty of Medicine at the University of Montreal. She is a specialist in nephrology and immunosuppression. And our last speaker will be Nathalie Grande, Professor, Department of Biochemistry and Molecular Medicine at the Faculty of Medicine at the University of Montreal, and Associate Scientific Director, Students and Postdoctoral Affairs, and Principal Investigator at the Centre de Recherche du CHUM. So these are our guests this morning. So since we have a visitor from Manitoba, Jason, we'll give you the first 5 minutes. I know you're very good in emerging viruses, and you have a very multidisciplinary approach to it. So you have 5 minutes.
Great, thank you so much, and certainly want to thank the organizers for inviting me for this. One of the things I think of when I think about the multidisciplinary area of my work, I think a lot of it is because maybe it's an attention span issue, or I continue to kind of feel a little bit inferior to those around me, so I feel like I have to broaden out my expertise. But somehow from growing up in Saskatchewan, I've ended up doing the thing that I've always dreamed of, which was working on emerging viruses, in particular working on things like Ebola virus. I grew up through the very late 70s and 80s and 90s. So I grew up during outbreak in the hot zone. So certainly got a taste of emerging viruses during that time. And being a kid that grew up in Saskatchewan, had this dream that at some point I would be able to do this. So did all my PhD and postdoctoral training in Canada, and moved to Washington, D.C. In 2009, and actually spent close to 8 years at the National Institutes of Health, mostly working in BSL-4, so working in high containment out in Frederick, Maryland. That also happened to coincide with the largest Ebola virus epidemic that we've ever seen, which happened in West Africa from 2014 to 2016. So spent time actually volunteering in the field to provide diagnostic support for patients for the country of Liberia. And that really changed my research focus. I think prior to that, I had certainly an interest in what happens within a cell when we encounter these emerging viruses, what happens at that very finite level between a virus and a host. But I don't think I had necessarily an appreciation for the clinical aspect and certainly the public health aspect of what happens in communities. And certainly seeing this firsthand very much, I think, shocked me. It certainly sits with me on a daily basis, and now really is a major part of my research focus. So we work on trying to characterize the circulation of these viruses in nature, trying to find out where they're hiding, where they're moving through, what precipitates these spillover events from wildlife into humans, but also this other aspect, which is what happens after outbreaks are contained. In particular with Ebola virus, one of the things we're interested in is we see certainly the virus getting into the reproductive tract of males. We see sexual transmission of this virus from patients who have no idea that they remain infectious and don't have any signs of overt illness. These are concerns for us from a containment aspect and certainly from a public health aspect, but also from a long-term health aspect as well. I think that there's a predisposition for us to look at outbreaks and think once things are contained, that's it, it's over. So we are trying to certainly look at this from a mental health aspect and reproductive health aspect in these patients. And certainly when COVID hit, you know, I was able to apply my skills very quickly, spent a year seconded in the University of Saskatchewan, providing research support and direction for COVID-related work because of certainly my past expertise and experiences in emerging viruses. And COVID has become very much a part of our research program. I think there's a time for people like virologists and biochemists and physicians and public health experts to really kind of stand up and take things by the reins when they can provide support and expertise, and hopefully I can continue to do my small part in that arena.
Okay, thank you very much. I'm very interested to see what links you can maybe provide us between your work in Ebola and the COVID-19 epidemic. So I'm sure questions will arise on that. Thank you very much, Jason. Maintenant, Dr. Marie-Josée Hébert, since you have, I think, a study going on immunodepression and the way that the vaccine worked, it's up to you if you have 5 minutes.
Thank you so much, Michel, and thanks to Natalie for inviting me. So I'm just going to preface my intervention by saying that I'm wearing my scientist and transplant physician hat this morning rather than my VP research hat, and it is sometimes confusing. I have to say that I'm still wearing many hats and that the pandemic didn't help. It didn't help because in some ways I think that we all felt compelled to serve and compelled to generate the much needed knowledge and helping us move forward in a way that was the most productive and the safest for the community, the population in general, but for some vulnerable groups within the Canadian population. And so I'm a transplant nephrologist, I'm a transplant physician, and obviously immunosuppressed patients are living through difficult times because they bear increased risk of morbidity and mortality associated with COVID, but they also are, and we know that from previous studies, they are more difficult to protect with immunization protocols because of their immunosuppressive state. So fortunately, amongst the various hats that I'm wearing, I'm the co-director of the Canadian Donation and Transplantation Research Program. And this is a pan-Canadian network that we launched in 2013. That really helped us, gather the expertise in a truly transdisciplinary fashion from coast to coast, and making sure that from basic scientists to clinical researchers to patient partners, we have a governance structure that helps us mobilize knowledge, but also define new research projects in ways that include the patient voice at the very center of what we do, and ranging really from basic science to population health. And so when the pandemic emerged, we tried to mobilize the network. But we very rapidly anticipated the difficulty associated with the state of immunosuppression in protecting our patients. And so in fall 2020, yeah, time flies with the pandemic. In fall 2020, then we really we reached a consensus that we really needed to think nationally and in a multidisciplinary way about how we will approach vaccination. And we had like a few research projects ongoing, trying to evaluate the severity of morbidity and mortality associated with COVID-19 episodes and transplant patients. But, vaccination was an important opportunity. And we knew that, especially in Canada, since we were amongst the, first countries where vaccination would become available, we knew that we needed to mobilize, and we needed to mobilize from coast to coast. And so we held a number of forums with our members, but also with major stakeholders. And so network was invited, FRQ, but also like PHAC and Canadian Blood Services and so on, but most importantly, patient partners. And so at the very start, when we started the conversation, we wanted to make sure that, we would develop research projects and programs on vaccination that would take into considerations not only the questions that we as scientists believe that are important, but the ones that patients and their lived experience see as important, patients and their family. And so this, after those two workshops, and we actually worked also with l'Institut National de Santé Publique in Quebec. So we really had like public health experts and vaccine experts, in addition to transplantation experts. And, we really developed a two-pronged approach to evaluating safety and efficacy in large cohorts in Canada, but making sure that we capture the information of immunosuppressed patients, but also developing a prospective cohort study for transplant patients, making sure that we have representation for the various types of transplantations, because they're not immunosuppressed in the same ways. So risk of COVID and efficacy and of vaccination will vary from one group of transplant patients, so heart versus lung transplantation versus kidney versus bone marrow. The outcome may be different. And so we're looking at their capacity to develop antibodies. We're looking at safety issues, but we are currently also looking at the persistence of their immune response to vaccination, if there's one. And those questions are still unanswered. So, we need to produce the knowledge in order to treat those patients. But I believe that the knowledge that we will gather in transplant patients may actually inform other groups of immunodysfunctional or immunodeficient patients, and also can inform us on what are the major immune pathways that are important in responding to COVID vaccination and in developing or not important morbidity and enhanced mortality after COVID episodes. So I think I'll stop there, and I'm looking forward to this discussion.
Thank you very much, Marie-Josée Hébert. Very, very interesting. What I keep from this is that there is a difference between the type of organs and the way that they react, and the efficacy is different from one transplant to another. That's very interesting. I'm sure we'll come back to that.
And it's actually, Michelle, if I can point out, we don't give them the same type of immunosuppressive regimen.
No,
so it's not really the organ, but it's the fact that, we don't modulate the immune system the same way.
Yeah, I gave a catchword here, but we understand that it's the fact that the drug regimen is different from one organ to another. Great. Now we already have a question, I think, but we'll continue. That's good news. We'll continue with Nathalie Grande, which is a specialist in antiviral molecules it's up to you, Nathalie. You have 5 minutes. Thank you.
Thank you so much, Michel. And so it's a pleasure to be here. So today, as Marie-Josée said, I have had several hats during the COVID pandemic since it started with the starting from basically nothing, the network, the RQCP, who is hosting the conference today. And so that was something very interesting in terms of, as was mentioned just before, like having seeing from the top, all the aspects of the COVID pandemic, not just what I do as research, being interested in viruses. So going from social sciences to, public health and all the other aspects that were related to the context of this pandemic. So that was the first one. But obviously, my main art is still to be a researcher. And so in research, I have been trained in cell biology and molecular biology and biochemistry. And for the past 15 years, my group, we have been interested in respiratory viruses. And actually, from a biochemical point of view, we use molecular biology, cell biology, and biochemistry to determine how the cells from the respiratory tract, and we have heard so much about them, during the COVID, especially at the start when we didn't know anything about the behavior of this new virus. So we try to understand in the respiratory tract what is happening at the very early time of the infection. So when the body encounters the virus, a respiratory virus, what is triggered, how the defense is started. And a specific aspect that we really would like to be able to understand better, and it would have been very useful to know that at the beginning of this pandemic, is this balance between what we call the antiviral response, so how the body fights the virus, the replication and the spreading of the virus. But the other part is the inflammatory response, which is part of this response. You need the inflammation of in the body to fight the virus. But on the other hand, the inflammation, if it is not controlled in terms of intensity and duration, then you will have systemic damage. You will have damage, of course, to the lung, but as we have seen with the COVID-19 pathogenesis, we know now that there is multi-systemic, multi-organ damage that is done, and that is in the most severe cases why the patients are dying from COVID. So this very early phenomena is surprisingly barely understood at the molecular level. And to my opinion, that is really key, and maybe we will discuss that today, but it's really key in terms of the drug regimen that we can give to a patient, because we need to give them ideally, if we would go through the drug design instead of the vaccination, you will have to give a molecule that will help the antiviral response. But at the same time, you don't want to increase the inflammation more than it is already triggered by the virus itself. So you need to play with that, and it's a tricky response. We can see it with what has been done over the past 2 years, is that when do you give an antiviral? When do you give the anti-inflammatory drug? Can you combine that? It seems not from what we have seen. We have some anti-inflammatory that are used now with the COVID-19 patient, but you need to give the anti-inflammatory drug later once the inflammation is there. But if you give it at the beginning, you're actually doing worse for the patient. So we basically try to figure out at the very micro level what determines this balance. And we try to identify targets that we could use to develop new antivirals more than the anti-inflammatory. But of course, all these drugs, we will test them to see their impact on the inflammation. And so that's what we do, what we have been trying to do over the past 15 years, and determines new cell target. And my vision on that is that, and it's good to have heard Jason speaking about Ebola, is that, to my opinion, we need to break the silos of the research done on one virus. We need to learn from what is common between all these viruses. And I was speaking about inflammation versus antiviral. Ebola is one of the key examples for that. So we really need to learn from other broad spectrum research that covers common path, from different viruses. So that's where we are going in the research that we are doing.
Merci beaucoup, Nathalie Granvaux. Thank you for giving us this different perspective. So I think all three of you have a different angle on the topic. So let's start with the first theme. And now I hope that everybody that is listening to us will have questions that will arise from the answers that you will give. So let's start by this vaccination event. Now, we never thought in 2020 that we would be using messenger RNA vaccines globally to the whole world. This is quite a scientific feat. Now, here in Canada, Pfizer and Moderna was used. It seems to show exceptional protection against severe symptoms, hospitalizations, and death. But there seems to be a lower effectiveness against infection and transmission. Even as we say that, we see that the fourth wave is not exactly as big as wave number 1, 2, and 3. So it worked. There is an effect there. Now, what are the prospects of what we've done? Can we use boosters to improve protection? Can we use other vaccines for better effectiveness? That's the first theme. I don't know if any of the three speakers can start by giving us answers to these questions. Jason, Marie-Josée, Nathalie?
Certainly, I can start off. I mean, I have a very I don't want to say a very global view, but it's certainly from my experiences. I mean, one of the things that I think we need to appreciate again is this idea of vaccine equity, right? That certainly, yes, we have great vaccines. We have vaccines that are highly efficacious, and even in regards to protection from infection, we've actually seen very good activity. It's not a binary yes or no. We actually see that they have actually held up very, very well. The issue for us moving forward, quite honestly, is that in the next few years, are we going to be able to curtail transmission in some of the most vulnerable regions in the world? Certainly areas that I work in, whether it is Sierra Leone, whether it's Kenya, whether it's Gabon, we are seeing low rates of vaccination. And certainly it is not just because of concerns in regards to vaccine hesitancy. In many cases, it is just supply. We do not have supplies that are getting there. So when we think about this idea of trying to curtail transmission, we have to think about it globally and certainly appreciate that basically the enhanced transmission that we see is going to continue to be a risk for all of us, right, regardless of what vaccines we are seeing. The second and third generation vaccines will hopefully build upon the technologies we've seen and certainly the robustness of the responses we've seen in the current vaccines, but we still need to get vaccines out to those areas of the world.
And as we open up to the world, the fact that we are very good at it, more than 83% of Canadians their two doses, opening up to the world, where in some countries it's very low, it's like 5, 10, 20%. Now we can have an influx of the virus coming in the country. How do we react to that possibility?
Go ahead, Natalie.
Oh, yeah. So I agree with what Jason said, and the fact that it's continuing the transmission in other parts of the world. It's a weakness for us if we think that we live in a bubble. It doesn't work this way. So the virus will come back, of course, because as you mentioned, the vaccine that we have used in Canada are very strong in protecting from severe symptoms and death and hospitalization. It's really good. So it's completely changed the profile of the fourth waves. That's definitely. But in a way, the transmission in other places is also lets the possibility of emergence of new variants in the other part of the world. And when they will come back, maybe our vaccine will not be as effective. And to put that in the balance in terms of vaccine equity, indeed, the vaccine that we use are less effective in protecting from the infection. So they're still decreasing it significantly, but it's not total. we agree on that. And so that there remains a part of possibility of transmission. It's decreased, but it's not complete. But we have other tools to protect the people in here from this remaining transmission. So I think for me, we have to be patient with this measure so that we can protect the other people on the other side of the world who have sometimes even not the measure, the public measure we have in here, and they don't have the vaccine. So overall, we will win if we protect everybody and we are patient with the public measure in here.
And I couldn't agree more with Jason and Nathalie. Like, this is a global responsibility, and we are going to, ultimately solve this problem if we work collaboratively, but with a global vision. If not, it's going to come back and bite us hard. And obviously, so we have we have darn good vaccines. And when the pandemic emerged, I would have never dreamt that in 2020, we had succeeded in developing new vaccines. This was unheard of. So I think that we really need to kind of measure how lucky we were, how fortunate we were that we could develop those vaccines. This was not what most specialists would have anticipated. However good they are, and they are incredibly good, I'm convinced that vaccination in itself, without other preventive measures, is not enough to control the pandemic. Not enough within one given jurisdiction, and certainly not enough globally. And I think that we need to coordinate the various actions and the kind of model that we use. And, trying to capture the imagination is the Swiss cheese model, where, if you need to, have various measures that will allow you to stop the various holes from, going through. So vaccines and, physical distancing and washing hands, but also new potentially preventive tools and the capacity to treat more rapidly, so that we would prevent severe diseases, and making sure that we could eventually shorten the duration of contagion. All of that needs to be taken into consideration, but all of that needs to be shared globally in a way that we optimize the way we control the risk, and that we minimize the risk of developing new variants. And I agree with Nathalie that if there is ongoing replication, that's how you generate variants. That's how viruses mutate. So if we don't have measures that allow in any population to prevent transmission, we are, just going to allow new variants to emerge, and the evolutionary pressure is going to be for those variants to evade the measures we have in place.
How do we address these new variants? Should we be giving a third shot of the existing vaccine, or should we wait and see if we can develop a new vaccine that will take care of the genetics of the new variant?
Maybe I can start with that. I think it's a balance of the risk. It depends on the population we are speaking about. We have started to give the booster for people over 65 who are in places where they are at high risk. And in France, for example, it's over 65 for everybody. Of course, there is more risk for them if the immunity is waning to then have severe symptoms and go back to where we were 2 years ago. So for this population, it might be of interest to get a booster before we get what I call the vaccine 2.0, the new version are more adapted. But overall, for the population, to my opinion, as long as we don't have a sign that the immunity is really waning and we will not have our health system overwhelmed, we might be able to wait for another type of vaccine adapted to variant. we don't have data on that so far, but I'm hopeful for this type of vaccine, or even completely other type of vaccine. There is some other options than the mRNA vaccine that are under research right now. So maybe something will come out.
Okay. Would you add something, Jason?
Yeah, no, I think it's a great point. And I think one of the things that we face, we have to appreciate again, and I think Dr. Hebert had perfectly summarized this, right? In 2020, when we think about the vaccines that were developed, this was unheard of, right? Historically, we will look back on that period and say, we did something that we never thought we could achieve. But the disadvantage to all of this is when we think about development of new vaccines, what we have to appreciate is as we start to tailor these vaccines, we also have to appreciate whether or not those vaccines are going to continue to provide the broader protection against different variants, right? So far, the original vaccines we've had have actually given very good coverage. We have not seen a variant yet that has been able to usurp the immune responses for people that are vaccinated. And that's really important. I think there is, I think certainly that concern that if you tailor vaccines, do you actually start to lose some of that? And listen, I don't know, but it's certainly something we need to appreciate, and we need people that are developing these vaccines to be able to actually put the time in to understand. So I think we're doing well with what we're doing right now. The vaccines continue to work. Delta certainly gave us a very large kick in the behind because it transmitted so rapidly. Will we see something that is able to basically usurp Delta in terms of transmission? I don't know. It would be surprising if we do see that, certainly. But I think that we need to see what our vaccine developers are saying and what they're seeing in terms of their responses.
Okay. Now, people that are listening have started writing questions. But these two questions I have are for the next topic of immunosuppressed patients for Dr. Hebert, so I think I'm going to wait. What I take from what you're saying to me is that incredible vaccines, they did what they had to do, and this phase, we have to watch out about global vaccination and the negative impact it can have here in Canada if people are not vaccinated around the world and come to Canada. So that is also a risk of getting the new variants coming in. So that's what I take from my first question. Yes, Dr. Hebert.
One little add-on.
Yes.
And again, adding to the fact that vaccination in itself, in my mind, is not sufficient. I guess that what's happening in the UK is something that we need to follow quite closely. Because they have, with regards to preventive measures, they have been very aggressive at allowing all those preventive measures besides vaccination to be forgotten. And they see actually a very rapid rate of transmission. They don't have a lot of severe cases, and so their health system is not overwhelmed. But the question is, are they playing with fire? So allowing a population-based high level of transmission, will that provide evolutionary pressure for a variant to escape the level of protection that we have with the current vaccine? Or is the virus stable so that it does not have the capacity to evade the pressure? And so I think that we really need to pay attention to what's happening in the UK and in other jurisdictions. I would not, for myself, be comfortable with such an approach here in Canada. And as my own take on that is that they are, somewhat playing with fire. But if they want to play with fire, we should learn from that, and we should make sure that we capture all the data from what is happening in the UK.
Thank you very much for saying that. We'll be talking in point number 3 about that, the public health measure, mass distancing, washing. So I think we'll come back to Great Britain on that topic. Nathalie, something else to
yeah, but I just wanted to add that unfortunately or luckily for us, there are other countries that have made different choices, and so the UK is one that is very important because they have a lot of data. They have collected and shared a lot of data on their population and on mostly a weekly basis. It's amazing. So we know, and they have their capacity of sequencing. So it's good because, of course, we will get information. The other country, and which is very interesting for that, is what is going on in Singapore these days, you know, because they have the kind of the highest rate of vaccination, but still the virus is spreading. So again, the system is not overwhelmed because, as Jason mentioned, the vaccine have done what we expected them to do, is protect people from being severely sick. But we will have to be careful. What I'm more worried about is the countries where the virus circulates, but don't have the capacity of sequencing. And when the traveling is going to be more important because we start to travel again, like people start to travel again, we may see some variant maybe circulating that we will not have catch up in the system because they don't have this capacity. And remember that in Canada, when a year ago, our sequencing capacity was very low. So even a country like us, we didn't have the capacity. So imagine some other countries. So maybe we will be protected, as Jason said, you know, it's difficult to foresee a variant that can compete with Delta at the moment. But this variant can go to population who are not yet vaccinated, and then we will have a global situation again. So that's the difficulty, I think.
Very important point. Thank you very much, Nathalie. I'm the guardian of time. I think we have to move, unfortunately, to the second topic, which is immunosuppressed patients. So Marie-Josée will have a lot to say about that. Immunosuppressed patients seem to show low reactivity to COVID vaccines and high risk of severe COVID-related morbidity. In that perspective, what kind of additional protective strategies and treatments can we envision for these patients? Monoclonal antibodies, more antivirals, non-pharmaceutical interventions. Maybe Marie-Josée, since this is your field, you can start with giving us a perspective on this.
And the answer would be, I guess, all of the above. But we need to gather the data to decide, you know, when to use what and on which type of patients. And so what we've learned so far from the data we've gathered, but also from, so we know, you know, that in Canada, we've started to give booster doses. Well, they're not third doses because in many of those patients, they're not booster doses. So, and in some types of transplant patients, we actually saw very low levels of anti-COVID antibodies being developed after the second dose. So, so there are, I guess, a number of factors that can add up to, in addition to the immunosuppressive regimen that can participate in a low and lower activity to vaccination, age being one of that. But also not only what you're taking as immunosuppressive medication currently, but the cumulative dose of immunosuppressive agents that you've received in the last year. And so if you're older with having higher levels of immunosuppressive regimens, your capacity to develop antibodies after 2 doses of vaccines is greatly reduced. And so that's why we had this recommendation from both provincial and then federal agencies to implement a third dose for immunosuppressed patients. And so we will be following those patients. We're currently doing the blood test to follow, you know, how much of these patients with a third dose, how much of them can we actually transform from non-responders into responders. So what we have learned from the reports that, you know, have been published mostly from Europe and the States, who've, you know, started doing that a bit earlier, is that we can actually, and in patients with abdominal transplants, so either liver, kidney, pancreas, and they're slightly less immunosuppressed than patients with thoracic organs, we can actually transfer them from a non-responder to a responder state, a fair number of those patients with the third dose. The jury is still out for patients with a higher level of immunosuppression and for older transplant patients, whether we will be able to transform them into responders after the third dose. We don't have enough data yet, but it looks like it might be more difficult. So the first question I saw in the chat was, what else? Like, are we going to be, for our transplant patients, are they going to be confined for the rest of their lives if they're 65 and above and they don't respond to vaccination? And I guess that there are various measures that we need to consider besides the preventive measures that we are already considering. Is that how do we, for example, household contacts? So are there interventions that we can do on the community and within household contacts that will in themselves have an impact on reducing the risk of contracting COVID in transplant patients? So those are more population health initiatives, but I guess we need to understand that when community transmission decreases, the risk for all people in the population, the risk decreases. So community measures will be beneficial to transplant patients, and controlling the risk of community transmission of COVID is going to have even a greater impact on transplant patients, because their risk of contracting COVID is higher than the general population. And then I think we really need to make sure that we can test additional measures in those patients. As pointed out by Nathalie, so will there be some antiviral molecules that we could use if those patients we know have been in contact with, so not, we're not going to give antiviral across the board. This would be dangerous. But if these patients who have an increased risk of contracting a severe disease and have an increased risk of not being fully protected with COVID vaccination, would they benefit from preemptive antiviral treatment if they have been in contact? This is something that we will need to look out and that we will need to test. And then there is also a question around, could we modulate, and Nathalie can speak to that, could we modulate the cells in the respiratory tract so that they become, less open to welcoming the virus, within the respiratory tract? And are there more almost physical methods of layering the pulmonary epithelium in such a way that it will prevent entry? But for all of that, we will need to do research, and I guess that's that's one of the important statements. We will all have to adapt and be willing to participate in new research projects, because all those questions will be answered by research, and we need to be committed to working together, making sure that we share knowledge. If not, it's going to take decades to get these answers. So we will need to do research, and we will need to do research in a very collaborative way in order to get those answers as fast as possible, but using the most rigorous methods and getting data that we can have trust in.
Before I let Nathalie and Jason answer to the big question, we have two questions here from people that are present. I will try and summarize them, because I think they come from the families of some of the immunosuppressed patients. Having, I think, two questions here. The first one is they seem to need guidance in the way of behaving with their parents that are isolated. And also the second problem is themselves being in a world right now which is probably not into a very strict public health measures like mask and distancing, which puts them at risk, even though they're vaccinated, of having the vaccine in an environment of immunosuppression. What is your guidance on that as a physician, Dr. Adair?
Yeah, well, I guess what we, the counseling we give to our immunosuppressed patients is to, maintain, so wearing masks, physical distancing, washing hands as much as possible. And after that, discussing that with your transplant physician, because there will be some, person-to-person variability. And that needs to be specifically discussed with the transplant physician. But in general, our advices are to maintain for the time being. So let's say that if we ease, and it is possible that, the sanitary measures will be eased in Quebec in the coming months, because the, fourth wave waving off, it is possible. But then we will probably ask for immunosuppressed patients to maintain a bit more measures than the general population. And so having a kind of wait and see attitude to see what happens to community transmission, and making sure that, they don't, as they bear additional risks of catching COVID, they will need to be just a bit more on the safe side than the general population. Their risk ratio is not the same as the general population, and that needs to be taken into consideration. But they need to have these discussions. So that's the kind of general rule of thumb. And after that, they need to discuss that with their transplant physician to see those advices adapted to their personal condition.
Okay. Thank you very much for that perspective, Marie-Josée. Nathalie Granvaux, would you have a word on maybe antivirals or?
Yes, alternative options, definitely. But before I go to that, just have a little word about what Marie-Josée just said, based on a discussion that was yesterday on the workshop on the long COVID aspect for the patient who have that, and many discussions that I had with the immunocompromised or immunosuppressed patient is that that works, keeping the public health measure at an extra level for the patient. But the society has to realize they exist. And, the public health organization, the government, and the insurance, because all these people, they cannot go back to their workplace with the same safety than other people. So we have to understand that not all the population is at the same level, and we need to have adaptation for these people. So that's a very good point that you mentioned, Marie-Josée, but we need to give this message out to the government that they need to take these people into account, and they will need special measures for the time being. But going back to alternatives, I think that, so Marie-Josée has mentioned everything that is happening in terms of the success of vaccination in the immunosuppressed patient, and it's very variable. I think one key point for these people that we could first do, and I still have difficulty to understand why we don't do that already, is that in research, we measure the efficacy of the virus, the vaccine, with the level of antibody or the neutralization antibody, and sometimes we have the capacity to measure the cell response also. But the patient, the immunocompromised or immunosuppressed patient, most of them, they don't know if the vaccine was efficient or not in their particular case. And I think that it would be helpful if we could have better criteria, better consensus of what is a good response, and if they have had a response to the vaccine, and if they can get a test to tell them, okay, the vaccine worked in my case. So in this case, at least we will have a part of this population, we will be reassured that the vaccine is protecting them. But for the other ones who have nothing, you know, I think there are options that are in development and some with some success. So the neutralizing monoclonal antibodies are an option that should be considered for these people. It is in the US. To my knowledge, and correct me if I'm wrong, it's not available in Canada for this patient, but the clinical trials have given some very interesting response for these people. So I think the neutralizing antibodies, again, as Marie-Josée mentioned, we cannot use that at large. You know, from the experience we have with neutralizing antibodies used at large, it was done for influenza, for example. Then we see resistance to this neutralizing antibody that develop. But for a smaller population, very specific population that need that for a short-term period to protect them in a time where there is high level of transmission in their area, it could be a very good response for them. It could be used. It's used, for example, for the respiratory syncytial virus for the newborn baby, the premature babies. We have highly successful prophylactic neutralizing antibody that can block, as you mentioned, the entry of the virus in the epithelial cells. And it has been working extremely well for the past 20 years. It's very expensive, so we should decrease this cost, but it's working well when it's used for specific patient, a specific cohort of patients. So that could be one way to go, and I think it's already well advanced so that it can become available for the immunosuppressed patient, hopefully in Canada in the near future. And the alternative, you know, for the antivirals, I don't think that's something we will have in the short term. So there are two molecules coming from Merck, and Merck is the more advanced. There is so Pfizer is on the line for an antiviral. I don't think they will be used at large neither, but we still have to see the data, the actual data about the safety and everything. So there is hope there, but as long as we don't have the actual data, I don't want to pronounce myself on the success of this option. But the alternative antivirals, we really need more research for that, because there have been millions of dollars put in trying to see whether all the molecules that are available, including all the FDA-approved drugs, worked against the virus. And basically everything failed so far. So we need more research, we need more target, we need new line of research to be able to find that. So I don't think this is a short-term option, but we absolutely need to work on that for the next crisis, the next pandemic, the next virus. And we should not stop as we have done in the past. So, and there is also, and maybe we can talk about that a bit later, but there is also the option, and maybe Jason will have an opinion on that, on the nasal vaccine that are under development. They are not ready yet, but it's also a good line. It's difficult to do, but it could work too.
That's a very good point. Annie Danielle Grenier asked that question in our Q&R. So maybe Jason, would you have an opinion on that?
Yeah, no, in regards to certainly second generation vaccines and further generation vaccines, I think there is certainly a push to try to see if we can go to a nasal based vaccine, right? Can we basically boost those IgA responses, certainly in the nasal passage, that will maybe help with blocking that initial infectious event with patients. I think that certainly, one of the things that we've learned is it's about accessibility. It's about our ability to deliver vaccines, certainly in different regions and in different settings. We have very diverse settings in Canada. We have to appreciate whether we're talking about northern communities or underserved communities, inner city communities, rural communities. We have to be able to get vaccines out. So I think that certainly there's an advantage to that. I think that it will help. It's not going to be tomorrow. I think that's one of the things we need to appreciate, is that we've had amazing advancements in vaccines, but we've also been a little bit spoiled by that, because when we think about drug development, this is not for a lack of trying to find antivirals or immunomodulatory therapeutics. It is not easy to do, which is why it's been so difficult for things like influenza. So to kind of parlay some of that back into this idea of what do we do for people that are in vulnerable communities. Again, this comes back to this idea that a lot of this is behavioral, right? So we certainly have we have individual choices we can make, but there are population-based choices that we have to make as well. Certainly, we are getting a greater appreciation for the role of ventilation. We are seeing a push to do that. Certainly, we have to appreciate that, yes, fomite transmission and surface transmission of COVID-19 has been very, very limited from what we've seen. But I would also acquiesce and say that we have to appreciate last year, we had an extremely, extremely low influenza season. So when we think about this idea of hygiene and the importance of hand washing, my comment back is that we have to continue to promote those behaviors because we are not dealing in a society where it is just COVID-19. So all those benefits we saw last year from our changes in behaviors in regard to other infectious diseases, that's what we can achieve when we continue to try to do these things. So a lot of it is promotion. A lot of it is, all of us trying to get out to those communities and provide certainly our voices when we can. It's uncomfortable at times. There are people that certainly are very, very hesitant or reluctant to hear about behavioral changes and things like masking and what this means for the long term. But I think the vast majority of people appreciate that these are important aspects that we need to be implementing to protect all of us. And that includes not only people that are seniors, but all those other high-risk groups that now we appreciate are vulnerable to COVID-19.
Okay. Thank you very much, Jason. As a moderator, I have just to tell you that time flies. This is such an intense discussion. It's already 11:30. We still have two other topics, so I think I'm going to give 15 minutes to each of the other topics. So everything is intertwined as we go forward here. So our third theme is something that everybody wishes, is to get rid of all these public health measures, mask distancing, washing. That's what the public wants. Now, what do the scientific community tell us about the short and medium term effect of getting rid of these measures? Or is this dangerous, like Dr. Hébert told us what's going on in Great Britain? So let's do a 15-minute talk on that and start with Marie-Josée.
So I really want to bounce back on what Jason just said. Yeah. I couldn't agree more. And I think that we need to take the lessons and the good lessons of what we've learned from the pandemic. We've seen reduction in most hospitals in nosocomial infection. And so those are infections that you catch when you are, you get admitted to the hospitals, whether you're immunosuppressed or not. And this is just because we're now, all personnel now is washing, like we were not, I guess the conclusion we need to draw is that all of us, whether we're healthcare professionals or patients or, family, we were not at baseline washing our hands enough. And it's not only COVID, it's bacteria with antibiotic resistance. It's influenza. It's a number of other transmissible diseases that we can actually control with behavioral changes. And it's obviously to the benefit of immunosuppressed patients, but it gets much larger benefits. But that calls for behavioral changes. And so I remember, decades ago, when we were trained as, scientists or physicians, even if you were sick, you would go in and you would still treat your patients because you are Superman and Wonder Woman. This is bad behavior. Come on. If you're sick and you have a transmissible disease, you should not show up in the hospital. That's it. And you should, when you have symptoms, you should wear your masks, whether we are in a COVID pandemic or not. And those behaviors are, have been, for example, in Asia, they're mainstream in Asia. We've been very reluctant in European and North American countries to adopt those behaviors. But they are positive aspects of this that we should not forget. That doesn't mean, maintaining everything that we have been doing for the past 19 months, but making sure that, as we say in Quebec, we don't throw the baby with the water in the bath, that, we keep the measures that will have broad protection against a number of transmissible diseases.
So should it be just washing that stays for years to come? What about distancing, masks? Should we get rid of these once the fourth wave is over? Jason, Nathalie?
Jason, go first.
So listen, I had the distinct pleasure of spending 12 months in Saskatchewan and getting back into Manitoba June 1, and really watched waves 2 and waves 3 roll through Manitoba. We had unprecedented stress on our healthcare system. Saskatchewan did not see much of that at all, but look how things have changed. Right. To me, when I look at the two provinces to the west of Manitoba, we've seen what happens when you abandon the majority of your public health measures, when you still have a highly transmissible infectious disease moving through a population, and you still have a significant number of people that are unvaccinated. This is really critical for us to keep in mind. And I think, again, we're learning where that threshold needs to be in regards to immunity in the population. But we also have to appreciate, certainly here in our province, we do not see this, homogenous, spread of people that are unvaccinated amongst vaccinated people, where, you may only have 10 or 15 or 20% that remain unvaccinated, but they're shielded by all these people that are unvaccinated. What we see is we have whole communities where there are low vaccine uptakes, and amazingly low vaccine uptakes as compared to regions with the highest uptake. So we have to continue to appreciate that if we remove all restrictions or all measures, there is a vulnerable community that is there that is going to suffer the consequences. And unfortunately, many of those people will likely not end up in the hospital, but some of those will. And we have never returned to a baseline level of hospitalization back in Canada from what we faced early in the pandemic. So I think we have to be very careful and very fluid in our removal of restrictions and measures, but also on an individual basis, appreciating that, this is not, 1980, smallpox has been eradicated, we all celebrate. As we start to, remove these measures, we have to be very, very cognizant of what our own behaviors are, what our own, health is, all the things that we've learned over this pandemic over and over again. We can't just dismiss those. It is too strategically important at this point in time.
Thank you very much, Nathalie. What is your take on this?
Yeah, I agree with what Marie-Josée and Jason have said. And I think in Quebec, we have been kind of lucky that we went really, step by step in removing measure. Our government has really taken this vision to go step by step, not in the very early time of the pandemic, but I think they learned the lessons. And now we are going very slowly. And I think it's a good thing. It's not perfect, but it's better than what we have seen at other places, definitely. One thing that I would reinforce is that, it's basically basic protection against infection, as Marie-Josée has very well explained. We need to get that in our behavior on a daily basis, whatever disease we have, and it's transmissible. One thing that we need, to my opinion, to be very careful with the COVID-19 specifically in terms of keeping the measure is masking. I know people don't like that, but the virus goes through the air. Right? It's very clear we need to protect against the transmission by the air. So masking is definitely the most simple procedure. I don't think we want to go back to isolation and containment. We want to avoid that. That's not something that's something we did because some people will discuss that, but we didn't know everything and we had to stop the propagation very hard at the beginning, but we don't want to go to that. It's not sustainable in the long term. But masking, when you are in contact with vulnerable people, when you have symptoms of whatever it is, I hear a lot these days, it's not COVID, so what? It can be RSV, influenza, it can be something else, and you will spread it anyway. So masking is the most simple way. And, I tend to say that there is very much less secondary effect of masking when you want to protect yourself and the people around you than having to take whatever drugs or things, because it's that's the way it is. It's simple. So we should change our behavior as a society, learn from that, and it brings me to something that happened even before, the pandemic, it was a month before the pandemic, and we, as Marie-Jose said, we had a meeting, and this person just came to work coughing like but so hard with the papers, just and say, okay, everybody will know I'm sick, and was at the end of the table, and I was like, that's not the way to behave, and but it was not understood before, and I hope that from this COVID-19 situation, people will remember that and keep using that, but we will need to reinforce this message. I think public health needs to continue to do that.
Okay. I have another point that Jason took up a few minutes ago, and that Nancy Delagrave asked as a question, and has to do with prevention also in public health measure. It's ventilation. She says that in countries like Belgium and Spain, they have imposed maximum CO2 levels and asked restaurants, gyms, hotels, and stores to display it. Should we do this in Canada and in Quebec? Is this a good preventive measure?
I can see that everybody is thinking very cautiously. Interesting, right? I mean, I guess my hesitance in how to answer it has been because this has become such a polarized issue, right? I think that certainly what we've seen has been, there are very opposite views on what to do with this. Listen, I stand somewhere, I hope, in the middle. I try to be centrist as much as possible, but I think that if we can provide extra protection, and certainly we can do it where it makes sense, and certainly where there's also data to suggest that it's beneficial, then we should be doing these things. But I also would say one of the things we need to consider again is this idea of underserved communities. What we have to appreciate as well is that we also have to figure out in underserved communities, certainly those communities that have borne the burden of COVID-19, how do we also ensure that that we are providing all of the additional measures that are needed in those communities to reduce transmission? So ventilation is certainly important, but we also have to look at the very basics as far as certainly healthcare access, paid sick leave, better masks, better access to rapid tests, mobile vaccine clinics. All of these things are part and parcel of a much larger picture. So my kind of wraparound answer for this is, I think if there's a benefit that is demonstrated, we should be doing whatever we can to try and curb transmission, and certainly do the things that will not only help us with COVID-19, but also beyond COVID-19.
Okay.
And if I may,
yes.
I guess my worry with the ventilation conversation, let's say, is that we shouldn't envision improving ventilation as a way to remove all other measures, and we shouldn't envision ventilation as a magic bullet. There's no magic bullet, and it really is the addition of various measures that allows us to control the situation, but one in itself is not going to solve the problem. So I guess yes, we should pay attention to ventilation. Masking is a way to paying attention to ventilation, because it's either you ventilate or you prevent that from gaining access to aerosols, but it's all of that works. It's not only one. And I think that we need to be ready to comply to a series of measures that are adapted both to our own personal risk, but to the general risk in the community.
And there's also a few questions going around about the quality of the mask, the N95 versus they say here, in Germany, it's the FFP2 mask that is required. Should we in Canada have norms? Should we just go about post-pandemic with a requirement of having masks of a certain quality or no quality at all?
Maybe I can jump into this one. So there have been a lot of debate on the mask and the, their efficiency, and I think we have some norms. They are not really well diffused in Canada, and in many places the surgical mask, do we say in English, is the one that is recommended. It's if it's well adjusted, and that's the one that is used in the hospital, it's definitely working for most of people. Going back to the immunosuppressed people, I think those people, you know, they are at high risk. So having a better mask could always first reassure them and to feel more protected, but they also, you know, they should be able to use them. So the data, you know, it's like many of the question in COVID-19. If we wait until we have all the data that demonstrate better efficiency than this, it may never happen in time. You know, it's complex to put in place. Most of the N95 are more adjusted, you know, for the shape. There have been a lot of improvement over the past 12 months because, you know, before when you were wearing an N95, you needed a fit test to make sure that it's really fitting to your face shape and everything. So, but we are not in a situation where people are working in environment like, you know, the confinement laboratories where you really need to have a fit. But in this case, if it improve the safety, you know, by being more adjusted and the filtration is good, if it's, you know, as good as what is currently recommended, I don't think we need to recommend N95 for everybody. I don't think that's justify, depending on where you are, the number of people around you, the you know, the situation, the risk. But we should allow people to wear them in a situation of risk for themselves, which is not the case right now. For example, you go to the hospital in Quebec, you're not allowed to wear your N95. So for immunosuppressed patients, sometimes it's a bit stressful, and I can get that, but you know, it's on the table. We don't have data to support if they are better or not, like in general, in every situation for every person. So it's complicated.
Okay, merci beaucoup, Nathalie. We have 15 minutes left. What I am proposing to you is that we try in 10 minutes to talk about long-term containment and suppression strategies in non-human animals. Maybe let Jason talk a bit about that. And I would like you, for all you three to maybe prepare a closing on how this pandemic had an impact in the preparedness of Canadian science and the strategies and beyond. How did this experience translate in research that you did, and how can we prepare for the next one? Would you like that as a closing argument, Marie-Josée, Nathalie, Jason? Just to close, I think talking about the future and what we've learned, I think would be a nice way to end. Perfect. So let's go to non-human animals and circulation of the SARS-CoV-2. What is your take on that, Jason, since you've studied so many viruses in animals?
Yeah, it's a great question, right? I mean, one of the things we have to appreciate is that right now what we are seeing, again, is, say it's unprecedented, but we are getting certainly a much greater appreciation that this virus it's fairly promiscuous, right? It moves not only into humans, but it also is moving into a number of other animals. Certainly, you know, we've seen, you know, a lot of surveillance data now on deer. We're certainly seeing it in smaller animals, zoo animals, you know, cats, great apes. The list goes on and on and on. And I think the more that we continue to test and do surveillance, the more animals we're going to find that are certainly could be infected. The role that they play in transmission back to humans outside of mink is not very well established. But that should also not preclude us from appreciating that there is a risk. When we think about this idea of viruses are very good at what they do. In many cases, they're very simple, but they've had eons of time to really, you know, kind of figure out how to move through different animals and circulate in the wild. So yes, vaccination is a massive part for controlling the virus and controlling transmission in our communities. We have to appreciate is that we still don't know what the specific reservoir host is for this virus. And to be fair, that's plagued us with Ebola for over 4 decades now. We have a proposed species. We still have not basically been able to isolate the infectious virus from the actual reservoir animal in the wild. That is difficult for us when we think about this idea of control of SARS-CoV-2, because the fact is it is circulating somewhere. We don't know which animal it is. We have a good idea. Those animals, if it is bat species, they don't show signs of illness, and it's not every bat that is infected. So this idea of looking at eradication as being a way for us to move forward, we have to kind of know that first part to be able to even get into question. The reason we did so well with smallpox was that it was unique to humans. We didn't have that extra aspect. But I think what's really critical for us now, and certainly, we look at the Coronavirus Variants Rapid Response Network, or COVARNet here in Canada, amongst other One Health folks in Canada that are doing this type of work, is to understand what is going on in transmission from humans to animals, animals to animals, and animals to humans. What does that look like? What is the virus doing? What behaviors are changing, if any? And what mutations are we seeing that are occurring as that virus passes through animals? Because this will start to give us at least some perspective on what the potential is for the virus to spill back into humans. And that, I think, really is important for us. We can go through all these steps to try and get as close to elimination as possible. But if we don't fully understand what that added piece looks like in wildlife, we could be facing spillovers again, and certainly without any appreciation for how to control these.
What about domestic animals, dogs and cats? I've had that question asked to me very often.
It's a great question, right? I mean, listen, we've seen the virus moving into cats, right? We've seen it moving into dogs, although it seems to be at a much lower rate in those animals. We haven't seen that transmission back, which is very, very important. But the aspect is that I think we need to consider is what is the commonality amongst all the animals that are being infected, and how long is the virus able to last within those animals? Does it continue to circulate, or does it basically go through an infectious cycle and then does not transmit onwards? So I think, again, we're learning information as certainly more people are doing surveillance, but it's been difficult. I mean, trying to do this type of surveillance in real time during a pandemic, it certainly is not easy from a resource standpoint, but I think you're seeing certainly a number of people that are stepping forward and saying this is a question we need to address, and we need to do it as timely as possible.
Because when it jumps from one species to another, it becomes a variant. It automatically changes its RNA structure.
Well, it changes in terms of mutations, right? And certainly, listen, variants are occurring all the time. We have to appreciate that when we talk about variants are happening as a person is infected, you are seeing mutations. Many of those mutations don't often amount to a change of behavior, but sometimes they do, which is where we get into variants of interest and variants of concern. So in animals, undoubtedly, we will see changes. This is what viruses do, regardless if they are more efficient at making copies of themselves than others. They like to, certainly RNA viruses like to make mistakes. The question is, do those mistakes in animals start to lead to enhanced transmissibility, immune evasion, enhanced spillover potential? We have good blueprints in an unprecedented period of time of what this looks like, or what it could look like. But now we have to actually do I think the real hard kind of feet on the ground work.
Maybe I can just, yes, I just wanted to add just a few words to just say that it goes far beyond the COVID-19 and the SARS-CoV-2. That's something that should become the norm in the infectious disease world, and the research that is done. We need, and that's something that we started a few years ago to call the One Health. It's something that is very important. It was already going on. It started small, but slowly in research around the world, this idea that we are not separated from the animal world, and we need to have this continuity of understanding the pathogens between the different worlds, and so this needs to be expanded. And that goes back to what I was mentioning at the beginning, that we need to stop working in silos. We need to work as a continuum between the different fields. And we try to do that in Canada through the Canadian Society for Virology to be able to discuss with people working on a virus on animals, for people working on the varum in Alaska, and trying to find all these virus, and even the microbiome, it's like it's the varum that we have in us. So it's all interconnected, and we need to have a different vision of research, and this applies to COVID-19, of course, but for the rest of the pathogens also.
Okay.
And if I may, Michelle, I'm really grateful to both of you that you brought up the One Health topic, because I think that is going to be, the main challenge for the, coming decades. I think that we need to stop, perceiving human health as something that's isolated from the rest. As, Natalie pointed out, human, animal, and the health of the planet, they're all interconnected. And we need to, be ready to appraise, characterize this in a global perspective. But for that, we need to change the way we're doing research, and we need to change the way we're supporting research, and we incentivize collaboration. And we need to, as universities, funding councils, and also scientific societies, we need to be ready to demonstrate that we're not paying lip service to interdisciplinary collaboration, but that it is the only path forward. That, we have been, many of us old enough, we evolved as scientists as, competing creatures. We need to develop, collaborative skills. We need to be open to various disciplines, and we need to use the new technological tools around big data and high throughput analytics and artificial intelligence as ways to crunch those data and develop new hypotheses and new path forwards. But for that, we need to have a plurality of disciplines and experts working together, and not one against the other. The pandemic proved that we can do it. I'm convinced that there are many more challenges ahead that might actually be even more difficult to solve than COVID-19, but we've learned that we can change the way we do research. And that's, I guess, what we should be looking forward. Okay.
But Marie-Josée, Canada is not a major player in the scientific field in the world. And when that happened in March 2020, Canada did its part and the rest of the world did theirs. What did we learn here in the scientific community in Canada about our preparedness to deal with such a scientific feat to try and beat this virus?
But Michelle, I think that as Canadians, we're too humble very often, and that we always think that, we are, not playing a major role. We're not the EU, we're not North America, but I think that we're a country that's highly respected for the quality of science that is being produced in Canada, and also we're respected because we have a track record of paying attention to the challenges in the fields of ethics and equity in science. And for that, since we have this track record, we have an additional responsibility to, maybe bring forward a discourse of changing the way that we support research and incentivizing ways of better collaborating. And I think that we are doing it, but we can do it in a way that's even more efficient and more nimble. But we're moving towards this direction.
Okay. Maybe Jason, do you have an international perspective working with Ebola and other viruses around the world? How did Canada do a good job, and what could we do better next time if we have another pandemic?
It's a great question, right? And listen, I think that when you look globally, preparedness certainly was not where it needed to be overall for this pandemic, right? And I think we better all appreciate that now, because this is not, unfortunately, it's not going to be the last pandemic that we face. Now, that being said, when I look at certainly the limitations that we face in Canada, I look at this more from certainly an infrastructure as well as a funding sustainability question. I think the quality of the science that's been done in Canada, when you look back, certainly, I'm very, very blessed in being in Winnipeg. The days of Ellen Ronald and Frank Plummer and Heinz Feldman and Gary Kobinger, Joan Embry, all these amazing researchers that have brought a public health flavor to infectious disease and have actually helped with circumventing international problems. I think that harkens back to what is in the Canadian research community. Certainly, Dr. Grande and I, in the Canadian Society for Virology, we are seeing this on a daily basis, not only from our researchers, but our trainees. So I think we have to appreciate the nucleus of researchers and expertise clinically, in terms of social science, in terms of biomedical research. I think it is unprecedented in Canada. I think the limiting factor, again, is this idea of resources. Can we provide resources and incentivize back to the research community to work with each other? We saw with COVID-19, with a global crisis, that the global community responded within days of the announcement of cases in Wuhan. We saw these collaborations being formed in real time through using social media and using other mechanisms. We have done that as Canadians. Now I think what we need to do is be able to provide sustainability to that. So let's not lose sight that when COVID-19 starts to drop off the radar and transmission rates start to drop, that everything goes back to normal. We have to appreciate that putting in good sustained funding is going to allow us to be more prepared and certainly be able to address an issue as it arises.
Great, Nathalie, would you have thoughts on that also?
Yeah, I agree with. So if we remain just on the infectious disease preparedness, I agree the infrastructure was really what was lacking, and it was probably because of a lack of vision of being able to work on something that is predictable but doesn't really exist. It's something that before the pandemic was a notion that was difficult to explain. You need to be prepared for something that you don't know what it will be. So the infrastructure we had years ago, for example, if we take the NC3, the confinement laboratory level 3, we had several of them throughout Canada, but it cost so much money to maintain them that many of them were closed or, degraded to level 2 because the institutions didn't see a need for that because there was no research on the pathogen for that. So, but restarting this infrastructure is it's taking a lot of time, and it's probably in terms of the early time of the pandemic what made some delay in the research. On the other side, and as Marie-Josée has mentioned, because we have this vision that is a bit different in Canada, the research on patient started very well and in a very good way, the quality of what has been done is really strong. And I think that what we need to discuss as a research community, and it probably applies to many other fields of research, which I'm less familiar with, is that how do we maintain the possibilities of doing research in terms of infrastructure, even if they are not used on a daily basis because we don't need them now. So that's a challenge because it requires a lot of funding for that. But also to come back to the collaborative work, it's working here in an emergency situation. But all our system, and it's true all over the world, but it's true in Canada for funding, is based on individual success. And so there is a discrepancy here between what we can do, how we could do research better, and what our leadership understands and wants us to do. So we need to have a voice on that to change, if we want to be more prepared in the future, we need to work together, different fields, different disciplines, but we need researchers to be recognized for that. Otherwise, it will never work.
Merci, Nathalie Grandvaux. This is a very good summary of what needs to be done. Time flies. It's already 11:59 for an hour and a half. I think we covered so many interesting topics. You were incredible, Jason Kindrachuk. Thank you very much for being here. Nathalie Grandvaux, merci beaucoup. Marie-Josée Hébert, merci beaucoup. So this was the event number 5 in this Réseau Québécois COVID-Pandémie workshops in order to think and reflect on how we need to do the science here in Quebec regarding this pandemic. My name is Michel Rochon. Thank you very much. And I wish you good luck in your work, in your research. What you're doing is very important for all of us in Quebec. Merci beaucoup. Au revoir.
Merci.
Merci.
Merci.